Welcome to the AristaMD webinar series. My name is Ed Cladera. I'm the Medical Director at AristaMD. This AristaMD webinar is titled eConsult Strategies for Managing Patients with Arthritis. The objectives are, number one, discuss arthritic diseases and associated medical complications. Number two, describe effective diagnostic and treatment methods available to PCPs. And three, delineate strategies to manage patients with arthritis. Our AristaMD presenter today is Dr. Rajat Bhatt. Dr. Bhatt is board certified in rheumatology and internal medicine, medical school at NGM Medical College, medical training at Mount Sinai School of Medicine and Louisiana State University, Shreveport. Today's webinar will have a questions and answers session at the end of the presentation. So if you have any questions or any ideas for future topics you would like to see in our webinar series, please don't hesitate to type these into your question box at the end of our presentation. We look forward to any feedback you may have. Without further ado, I will turn it over to our presenter, Dr. Bhatt.
Thanks, Dr. Caldera, for bringing me in. It's been a pleasure speaking with you. Thanks for taking the time to attend this conference. My name is Dr. Bhatt. I'm a practice owner of Prime Rheumatology. This is a rheumatology practice located in Houston. We see a large variety of patients from PCPs, and we appreciate the hard work that primary care physicians put in to help evaluate these patients. In this conference, we will discuss the common causes of joint pain. How do we examine the major joints, knee, ankle, apex, elbow, shoulder, etc., and to provide a systematic approach to investigation and generating a differential diagnosis. To be familiar with diagnosis and treatment for important joint problems, I will touch on rheumatoid arthritis, osteoarthritis, gout, septic arthritis, tendinitis, and also familiarize you with referral criteria, when to refer to a rheumatologist either in person or to us for an eConsult so we can guide you appropriately. So it's important terminologies are arthralgia is pain, inflammation is arthritis. We look for certain signs of inflammation, redness, warmth, and swelling, which goes in favor of inflammatory arthritis. If it's just a single joint involved, it's called monoarticular. There could be multiple joints involved as well. But remember that not all pain is arthritis. It can be from mechanical problems. It can also happen from inflammatory arthritis. Usually they have pain at rest. There may or may not be fluid within a joint. Joint pain may also arise from structures within the joint. For example, the sources of pain could be the joint capsule, periosteum, ligaments, synovium, subchondral bone. But usually it's not the articular cartilage, which does not have nerve endings. It can be inflammatory, which could be infectious, rheumatoid, crystal deposition. It could be psoriatic arthritis. Non-inflammatory is osteoarthritis or from mechanical derangements. Joint pain may also arise from extra-articular structures, bursitis or tendinitis, or even extra-articular disorders. There could be inflammation outside a joint, for example, in polymyalgia rheumatica, and even fibromyalgia may present with joint pains, but they are not necessarily structural or inflammatory processes going on in the joints. There may also be referred pain from more distant sites. And there may not be any musculoskeletal problem, but just a referred pain from some other site. Mono or oligoarticular joint pains usually involves less than 4 joints. The reason I'm introducing this concept is because it helps in the differential diagnosis later. So mono or oligoarticular pain involves less than 4 joints. Usually it could be traumatic. Fractures can cause hemarthrosis. It can be internal derangements or any mechanical trauma. Meniscus injuries, ligament tears can cause mono or oligoarticular problems. Infectious and septic arthritis usually are oligoarticular or monoarticular. Then there's a whole group of disorders called seronegative spondyloarthropathies, which we'll discuss later. These are, for example, in Behçet's or Reiter syndrome or inflammatory bowel disease, which involve less than 4 joints. Psoriatic arthritis is another example. Crystal-induced disease usually involves less than 4 joints, but it might be polyarticular. Then there are periarticular syndromes, bursitis, epicondylitis, tendinitis, which usually are which are oligoarticular. But note, this is not all set in stone. There's considerable overlap. For example, a person can have gout at multiple joints, and it might involve 5 joints. A septic arthritis can involve multiple joints and be polyarticular. This is just to generate a differential. It gives certain points to generate a differential diagnosis, but this is not all exclusive. Monoarticular pain, there are uncommon causes. Avascular necrosis is one in which patients have used corticosteroids or the sickle cell. Neuropathy can present as joint pains. Osteomyelitis can present as joint pains. Lyme disease, but the geographic distribution is important in that differential. Paget's disease can sometimes present as joint pains. It could be a malignancy, a tumor within a joint, but may not be an arthritis per se, but that could present as joint pains. Rheumatoid arthritis usually is polyarticular, and thus it's an uncommon cause of a monoarticular pain, but it can present that way. Polyarticular joint pains usually involve more than 4 joints, and we have acute polyarticular arthritis. Usually it's we rule out infections, or it could be a flare in rheumatic disease. A person could be well-controlled rheumatoid arthritis, so only has an acute flare. Chronic polyarticular arthritis is most often due to rheumatoid. It could be osteoarthritis, could be psoriatic arthritis. In children, chronic polyarticular arthritis usually involves most often due to juvenile idiopathic arthritis. The details of JIA is outside the scope of this talk, as it's extensive. It involves the 6 subtypes of juvenile idiopathic arthritis, and each follows its own course. Symptoms of joint disease usually are pain. Inflammatory joint disease, the pain usually is at rest and with motion. It is worse at the beginning, and movement actually makes it better. In non-inflammatory joint disease, it's usually the other way around. The pain worsens with movement and improves with rest. But once again, there's considerable overlap. Person with advanced degenerative disease can have pain at rest and at night as well. And a person with advanced rheumatoid arthritis, for example, might have pain worsen with activity. Symptoms of joint disease: stiffness. It's a perceived sensation of tightness when attempting to move the joints. Usually subsides with time. The duration is important here to distinguish inflammatory from non-inflammatory causes. With inflammatory arthritis, the stiffness is present upon waking and typically lasts a few minutes or longer. With non-inflammatory arthritis, the stiffness is experienced briefly, 15 minutes. Usually with inflammatory, the stiffness will last an hour or longer, so that's significant. Then there's swelling. With inflammatory arthritis, the joint swelling is related to synovial hypertrophy and effusion, and inflammation in the periarticular structures. The degree of swelling varies with time. So for example, a person might be rheumatoid arthritis, but would be taking NSAIDs when he presents to the doctor's office, and that could be improving the swelling. So the doctor might not see all the features suggestive of rheumatoid arthritis because the patient has already self-treated himself with NSAIDs. With non-inflammatory arthritis, the formation of osteophytes leads to bony swelling. And there's a very typical picture for osteoarthritis, which I will show later. These patients might also have mild degrees of soft tissue swelling. And this could be due to synovial derangements, which are primarily mechanical, not inflammatory. Another common symptom is fatigue. It's usually synonymous with exhaustion and depletion of energy. With inflammatory arthritis, fatigue is noted in the afternoon or early evenings. We have psychogenic disorders, and then we also have fibromyalgia, in which the patients might complain of fatigue all day long. Once again, as I mentioned, there's a significant overlap. We can have rheumatoid patients who are fatigued all day long as well. Then we look at the temporal pattern of arthritis. So this might be abrupt or insidious. With an abrupt onset, it develops over minutes or hours. This usually occurs in trauma, crystalline synovitis, infections. Insidious pattern develops weeks or months. It's usually typical for most forms of chronic inflammatory arthritis, which is rheumatoid. It can also happen in osteoarthritis. The presence is usually insidious. Duration of symptoms is also acute or chronic. Acute is less than 6 weeks. Chronic is 6 weeks or more. The temporal pattern of joint involvement are migratory, additive, or simultaneous and intermittent. So with a migratory pattern, inflammation persists for a few days in each joint and then goes away and then affects another joint. With an additive or simultaneous pattern, inflammation persists in involved joints and new joints keep getting involved. With an intermittent pattern, episodic involvement with intervening periods free of joint symptoms. Usually gout has an intermittent pattern and lupus has a migratory pattern. With additive pattern, usually it's rheumatoid arthritis. Number of involved joints. Monoarthritis, as I mentioned, is involvement of one joint. Oligoarthritis, 2 to 4 joints. Polyarthritis, 5 or more joints. Symmetry of joint involvement. Symmetric arthritis is characterized by involvement of the same joints on each side of the body. This symmetry is typical for RA and SLE. Asymmetric arthritis is characteristic of psoriatic arthritis, reactive arthritis, and Lyme. Note that these features are common to seronegative spondyloarthropathy. Asymmetric is also common in infectious arthritis and traumatic arthritis. Distribution of affected joints is important. The DIP joints are usually involved in psoriatic arthritis, gout, osteoarthritis, but are usually spared in RA. For some reason, the rheumatoid arthritis does not usually affect the distal interphalangeal joints of the fingers, so that is important. The joints of the lumbar spine are usually involved in ankylosing spondylitis, but are spared in rheumatoid arthritis. Rheumatoid arthritis can involve the cervical spine and cause neck pain, but usually spares the sacroiliac joints. Distinctive types of musculoskeletal involvement. Spondyloarthropathy involves enthesitis. Enthesis is where the tendons attach to the joint, and enthesitis is when there's inflammation in that structure. So heel pain is where the Achilles tendon attaches to the joint. So that's significant for spondyloarthropathies. So we look for tenderness in the Achilles tendon or plantar fascia. Back pain and tendinitis. Gout commonly involves tendon sheaths and bursae as well, which can result in superficial inflammation. There are extra-articular manifestations that are important as well. Constitutional symptoms, which suggest an underlying systemic disorder, not expected in patients with degenerative joint disease. But once again, we have to look at objective criteria. For example, we can have fibromyalgia patients presenting with constitutional symptoms. So we ask for more objective criteria like weight loss, fever, etc., lymphadenopathy, etc. Skin lesions may indicate a specific diagnosis of a number of rheumatologic diseases. Examples include SLE, scleroderma, and psoriasis. We look at ocular symptoms and signs, episcleritis and scleritis associated with rheumatoid arthritis. Anterior uveitis. This is inflammation of the eye. This can happen in ankylosing spondylitis and psoriatic arthritis. So this is important since not all rheumatologic diseases involve just muscles and joints. Certain arthritis can affect the eyes and certain other structures. Iridocyclitis is a feature with JIA. Conjunctivitis may be caused by reactive arthritis. We also look at the patient could have bacterial infections. So they could be non-gonococcal or gonococcal. We look for history of trauma. We look for history of sexually transmitted diseases. And once again, the gonococcal would have a migratory pattern of tenosynovitis, and there would be certain skin lesions involved. Then there is crystal-induced arthritis, which can be gout or pseudo-gout. Trauma. Then there's a new entity, and let me correct that. There's an inflammatory back pain, which has a considerable overlap. In the past, we used to consider ankylosing spondylitis as a typical prototype for inflammatory back pain. But in the past couple of months, there has been increasing recognition for some entity called non-radiographic spondyloarthropathy. So we look for certain criteria. So not all back pain is mechanical. It could be inflammatory. The things that we look for is spinal pain, low back pain, age less than 50 years, the duration of back pain more than 3 months. The age at onset should be preferably a younger age group, 20s or 30s. Morning stiffness for more than 30 minutes. The pain characteristically will improve with exercise or activity, and it is worsened at rest. There could be alternating buttock pain, and also this pain does get better with NSAIDs. If you have such a patient, to refer the patient over to our AristaMD to make a determination if the patient needs to see a rheumatologist in person, since there could be a certain proportion of patients who could have inflammatory back pain and not mechanical, and they need to be identified since we have newer drugs on the market now like Cimzia available. Once again, these are certain other classification criteria for inflammatory spondyloarthropathy. HLA-B27, history of psoriasis, bowel problems, if they have had eye problems, or any finger swelling, that is called dactylitis, is basically swelling of the fingers or toes. Refer them over since they could have inflammatory back pain. Or if they have a family history for inflammatory back pain, that also becomes important. The differential diagnosis of chronic monoarthritis includes inflammatory monoarthritis, as discussed. It could be infectious, it could be crystal induced, it could be monoarticular atypical presentation of polyarthritis or oligoarthritis process, like rheumatoid or lupus. It could be sarcoidosis. There are rare causes which could include amyloidosis, familial Mediterranean fever, foreign body. Quite often patients do injure themselves and may not realize it. The foreign body gets embedded and presents years later as a monoarthritis. So that is an important differential. Pigmented villonodular synovitis is a rare tumor condition in which the patient can have monoarthritis. And there is non-inflammatory monoarthritis, osteoarthritis, derangements, chondromalacia patellae, osteonecrosis, Charcot arthropathy, sarcoidosis, amyloidosis. Once again, there's considerable overlap. I might have labeled it as uncommon or rare, but depends on the population you're dealing with. For example, familial Mediterranean fever could be higher in patients with, in the population that has a high ethnic population. And Charcot arthropathy is common in the diabetic population. So it depends on the prevalence of other comorbid illnesses in the neighborhood as well. There's differential diagnosis of polyarthritis includes acute polyarthritis. Common causes are viral infections, rheumatoid disease, lupus. Uncommon are paraneoplastic polyarthritis. There's something called the easy word would be just RS3PE. This is a rare condition in which patients have a boxing glove appearance in which both the hands get swollen, similar to boxing gloves. At that point, do refer the patient to a rheumatologist, since this is not to be missed and can happen with a malignancy. Acute sarcoidosis, Still's disease. The details of Still's disease are outside of the scope of this talk. Basically, the patients have high spiking fevers and a rash at that time. Secondary syphilis is rare. It used to be common in the past. Systemic autoimmune diseases and vasculitis can also present as polyarthritis. So in those cases, constitutional symptoms become important. Fever, weight loss, lymphadenopathy, history of malignancy, or any purpuric rashes that are developing. Chronic polyarthritis can be from common causes. Inflammatory causes are rheumatoid, lupus, spondyloarthropathy. Chronic hepatitis C can also cause an infectious inflammatory cause of a chronic polyarthritis. Gout, then the certain drug-induced lupus syndromes can cause chronic polyarthritis. Rare causes include paraneoplastic polyarthritis, which are associated with malignancy, RS3PE, which I mentioned before, Still's disease, systemic autoimmune disease, and vasculitis. Sjogren's syndrome. Sjogren's syndrome usually causes polyarthralgia, can cause polyarthritis as well. Viral infections other than hepatitis C. Then there are non-inflammatory causes, which are primary generalized osteoarthritis can cause a chronic polyarthritis, hemochromatosis, calcium pyrophosphate deposition disease, CPPD. These are certain crystals that get deposited, usually seen in an older age group, also seen with endocrine problems. So if the patient has hypothyroidism or hyperparathyroidism, they are prone to develop CPPD. That's the acronym for chronic pyrophosphate deposition disease. So osteoarthritis, this is a typical osteoarthritis picture. You're seeing this knobby fingers. This is the DIP involvement. So these are called Heberdine's and Bouchard's nodes. What's important to remember is these fingers do not have a squishy feel to it. They feel hard and bony, but not squishy. Clinical differences, this is a slide to summarize. Osteoarthritis and rheumatoid. Rheumatoid would have morning stiffness more than 30 minutes. There's extra-articular involvement. Symmetric. Osteoarthritis is asymmetric. You're seeing the knobby fingers, cartilage loss. Morning stiffness is a brief duration. These are rheumatoid arthritis deformities. So there has basically been subluxation of the fingers, swan-like deformities, ulnar deviation, botanic deformity in the thumb. This is a typical deformity of psoriatic arthritis. Here we're seeing this is what we see, dactylitis. This finger is swollen like a sausage. The nails are peeling off, and there's significant psoriatic involvement. When you see this, refer them to a rheumatologist, ideally in person, since they might need aggressive, DMARD, and possibly biologic therapy. The physical examination is important. It helps distinguish joint inflammation from joint damage. Also reveals the site of involvement, synovitis, enthesitis, tenosynovitis, or bursitis, and the distribution of joint involvement. So in general, we check for fever, we check the vitals, look for inspection, palpation, range of motion, and special tests. Joint inflammation, we look for swollen, red, hot joints. We look for passive and active movement to look at the functional impairment in this patient. We look for crepitus during active and passive range of motion, joint instability, joint deformity. These could be several types of deformities: dislocation, subluxation, or flexion extension deformities. Swelling and ecchymosis indicate a fracture, complete ligament. We look for certain other features around the joint. If there is any swelling or ecchymosis around the skin, we also look for any surrounding cellulitis if there's an infectious cause for monoarthritis. We look for joint laxity, deformities. Look for crepitus, indicates a derangement of bone, cartilage, or menisci. The laxity is tested usually by a range of motion, and we're assessing the ligaments in that situation. We also look at joint. If the joint volume is increased, the physician should determine if this is hypertrophy or a joint effusion. We determine the range of motion. Increased range of motion usually indicates an unstable joint. Decreased range of motion may represent effusion, capsule fibrosis, or bony abnormality. Certain red flags that should prompt an urgent workup include warmth, erythema, swelling of the joint, which might indicate the need for a further workup, as infection, rheumatic process, and crystal arthropathy. If there's other joint involvement, as I mentioned about inflammatory back pain, if the patient has pain in the early hours of the morning, which are improving with activity, getting better with NSAIDs, young patient, psoriatic rash, HLA-B27, consult rheumatology. Extra-articular features, nail pitting, tenosynovitis, nodules, conjunctivitis, mouth ulcers. These are important in the differential. Suggestive findings in polyarticular joint pain, there could be bone tenderness or chest pain. They could be coexisting tendinitis. We look for gonococcal or rheumatoid disease, conjunctivitis, abdominal pain and diarrhea, which can happen in reactive arthritis, can also happen in inflammatory bowel disease. Fever and malaise, infection, gout, vasculitis, rheumatic disorders. Malaise and hyperlymphadenopathy can happen in acute HIV infection, can also happen in lupus. Oral and genital ulcers, Behçet syndrome, again happens along the Silk Route. Certain ethnic populations of Turkish descent and along the Silk Route. It is rare in the United States, but we are always surprised we see some patients with those syndrome. Raised silver plaques, which might be of psoriatic arthritis. Recent pharyngitis and migrating joint pain, which can happen in rheumatic fever. Recent vaccinations of blood products, serum sickness. This is rare now, used to happen in the past. Skin ulcerations, rash, abdominal pain, which can happen in vasculitis. Tick bites. This is more common in certain areas, the Northeast or Midwest, from Lyme arthritis. In the Houston area, there's a Lone Star tick that can cause something similar to Lyme arthritis, but not exactly the same. Urethritis is an important feature for gonococcal or reactive arthritis. Lab studies rarely provide the diagnosis in joint pain. It's primarily history and physical examination are 60 to 70% of the work. Lab studies would be about 10 to 20%, and further by imaging. So blood testing is ESR, CRP, rheumatoid factor, ANA, uric acid is only useful if there's a high suspicion of a pretest probability. These tests are high sensitivity but low specificity. ESR and C-reactive protein are commonly elevated in inflammatory conditions like rheumatoid and septic joint. They can also be elevated in psoriatic arthritis. In lupus, usually we see a dissociation. The ESR is elevated, but the CRP is not. CBC may show anemia of chronic disease. Sometimes we might find a malignancy in the CBC itself. Arthrocentesis is another feature a tool we commonly employ. So this is a synovial fluid analysis. This is usually indicated when there's a warm red joint with effusion and no history of trauma. Another time to consider arthrocentesis is when a significant effusion is present, even if it's a cold effusion, because this might lead to functional improvement. The aspirated synovial fluid should be sent for cell count, crystals, and culture. Diagnostic imaging. Key indicators for diagnostic imaging are bony tenderness, inability to bear weight, gross deformities, skeletal immaturity, and age. Plain films remain the screening modality of choice for most joint abnormalities. They should be performed in all cases of significant joint trauma, chronic pain, and suspected arthritis. We're looking for fracture, malalignment, erosions, loss of joint space, and widened epiphysis. Looking at the MRI and bone scan as well. Usually PCPs might need X-rays. Do consult us early so we can guide on the appropriate imaging modality. The EULAR criteria were developed in 2010. They assign a scoring system to help evaluate for rheumatoid arthritis. Basically, we assign points based on the joint distribution, serologies, symptom duration, acute phase reactants. So one large joint gives a 0 score, 2 to 10 large joints 1. We try to total up the score and see if the score is more than 6. If the score is more than 6, that goes in favor of rheumatoid arthritis. The criteria might be fulfilled prospectively over time or retrospectively if we have firm data on all the 4 domains. But note that once again, this is helpful in the diagnosis, but clinical gestalt is more important. We could have rheumatoid arthritis, seronegative rheumatoid arthritis, which are involving only one or two joints, and with a normal ESR and CRP as well. When in doubt, consult us, because certain things will depends on comes with experience, and it's hard to put it down on a single slide. Criteria for developing psoriatic arthritis. These were the Casper criteria that were developed. These assign a point system to a current psoriasis, a family history of psoriasis, psoriatic nail dystrophy, negative rheumatoid factor, dactylitis, and radiographic evidence of juxtaarticular. That means there was new bone formation on in the articular space. But the Casper criteria have sensitivity of 91%, specificity of 98%. But these were this study was done in patients who had already been pre-selected for inflammatory arthritis. From the primary care standpoint, this could lead to false positive results. So this is useful, but not diagnostic. In evaluation, we look at polyarthralgia, we look at synovitis. It's just a flow chart to help guide you as to the approach for further workup. If they have synovitis more than 6 weeks, we'll work up for systemic rheumatic disease. We perform CBC, ESR, rheumatoid factor, CCP. We do ANA, UA, and joint aspiration if there's an infusion. It could be viral arthritis, which we can just carefully follow up and see if this resolves. If it ends up being chronic or persistent, we can work up with hepatitis B and C serologies, as they can be infectious chronic polyarthritis. If there are tender points, it could be fibromyalgia. We also look for endocrine problems. Hypothyroidism can cause a syndrome similar to fibromyalgia and cause joint pains. Metabolic bone disease, hyperparathyroidism, Paget's disease can cause joint pains. Depression may cause joint pains. So we might need further workup with liver function tests, hepatitis B and C serologies, radiographs, calcium, thyroid function, alkaline phosphatase. Now we come to the management. Non-pharmacological therapies basically are employed to limit swelling and pain. The mnemonic PRICE sums it up: protection with a brace or a wrap. Rest to avoid activities that cause pain or an increase in swelling. Icing 15 minutes several times per day. Compression with an elastic wrap. Elevation of the joint above the level of the heart. Note that all this does not have to be used, just a combination of these. Massage therapy may also help relieve muscle spasm and facilitate stretching. The non-pharmacological therapies also include education and behavior changes. The patient may engage in other activities to maintain strength and endurance. Swimming, stationary cycling are commonly recommended. It is important to not encourage disability, and unless the patient truly is unable to function, we usually encourage them to stay active in whatever way they can choose. If there are certain joints that are painful, we encourage them to move the other joints and stay active, because a disability starts a downhill spiral and worsens depression, and at some point it leads to social exclusion. Office interventions include several interventions might greatly reduce pain and protect the affected joint. Taping, splinting, casting might help immobilize the joint or minimize pain with activity. Intra-articular injections might be effective. They're more effective in inflammatory pain than in osteoarthritis-related pain. And steroids should not be injected into the tendons, cartilage, or ligaments. As chronic joint pain, physical modalities, again, improper or excessive exercise can also hasten joint damage. Thus, it's always encouraged to start an exercise program in conjunction with a physical therapist who is well trained. Walking programs, swimming pool therapies can help. As I mentioned, intra-articular steroid injections can provide short-term pain relief. The benefit is more when effusion is present and aspiration of synovial fluid at the time of joint injection is successful. Education and behavioral changes. Education on what to expect from the disease has been shown to improve outcomes in chronic disease states, including arthritis. Behavior changes such as positioning, work pacing, and diet leading to weight loss may improve symptoms, especially in osteoarthritis patients involving the knees and hips. Weight loss does lead to significant improvement in symptoms. So not all treatment involves pharmacotherapy. There are certain things the patient can do to help improve the joint pains, different from pharmacotherapy. Analgesics involve acetaminophen, that's the time-tested analgesic, NSAIDs and COX-2 inhibitors, opioids. There are certain adjuvants and concomitant therapies. Muscle relaxants in combination with NSAIDs are commonly used in the treatment of muscle spasm and injury. They can lead to sedation. Topical medications are very useful for treatment of acute pain as well as chronic pain. For example, diclofenac gel and lidocaine gel. In the past, we used to encourage for joint pain, but not any longer. Currently, the guidelines discourage use of opioids for chronic non-cancer pain. Certain other therapies might become important in different kinds of arthritis. So septic joint, antibiotics. In gout, we can use colchicine or allopurinol. Muscle spasms, we can use muscle relaxants. Neuropathic pain, topical capsaicin and antidepressants. Associated muscle pain, topical or oral NSAIDs, topical lidocaine. Rheumatoid arthritis, DMARDs, steroids. Steroids are only used for short-term relief of inflammation, not for long-term pain. Osteoarthritis, we can try glucosamine, but the benefit is not conclusively proven. Another option is diclofenac gel, especially in elderly osteoarthritis patients, since it does not have significant side effects of oral NSAIDs. Intra-articular injection of steroids might be considered. Aspiration of the joint, as discussed. Tricyclic antidepressants and antiepileptics may also modulate the pain signals. Patient might also need referral to a pain medicine specialist in case of intractable pain. Glucosamine and chondroitin may be useful to improve osteoarthritis symptoms. The role of glucosamine to slow joint space narrowing is controversial. Some papers have shown it, but other studies have not. The role of primary care doctors are, in general, they're responsible for recognizing early arthritis and providing a rapid referral to a rheumatologist if needed. Second important role for PCPs, and even more important, is the ongoing management of key comorbidities in patients with arthritis. These include cardiovascular risk factors, weight, mood, sleep disturbances, osteoporosis, also helping with medication side effects. These patients might end up on DMARD therapy, and they require ongoing monitoring for side effects of those therapies. So this has to be done in conjunction with a rheumatologist. Prompt referral should be made whenever there's a concern about the diagnosis, discomfort in prescribing certain medications, and minimal progress with the treatment plan. When inflammatory arthritis is diagnosed or suspected, immediate referral to a rheumatologist is recommended for confirmation of diagnosis and initiation of DMARD. Red flags which physicians should watch for so that they can refer immediately would be systemic symptoms, weight loss, fatigue. Arthritis can be a unusual presentation of vasculitis or malignancy. So patients can have lymphadenopathy, weight loss, fatigue, and monoarthritis or oligoarticular arthritis usually. And this can be an early symptom of malignancy or a vasculitis. Skin rashes, psoriatic arthritis, if they have any skin psoriasis or a family history. If there's suspected vasculitis, the patient is having multiple constitutional symptoms. Vision changes. Uveitis can coexist with arthritis and be sight-threatening, thus refer to immediately to rheumatology and ophthalmology preferably. High fevers, infection, endocarditis. If the patient has an ongoing endocarditis, it could be a septic joint. Physical medicine and rehab specialists are specifically trained to help maximize physical function and quality of life. Significant disability should prompt referral to an orthopedic specialist for evaluation of possible joint replacement or debridement. Pain clinics can also provide assistance with medication management, especially with the opioid use if the patient needs those. The treatment algorithm would involve pharmacologic treatment and non-pharmacological treatment. To sum it up, pharmacologic involves analgesia, acetaminophen, COX-2 inhibitors, tramadol, opioids. Adjuvant treatment would be tricyclic antidepressants, antibiotics if needed, antiepileptics, not commonly used, but sometimes for pain management, colchicine, topicals, muscle relaxants, glucosamine. Colchicine is used in gout as well as sometimes in CPPD disease as well. Non-pharmacologic treatment involves physical modalities, education behavioral changes, office interventions. Prompt appropriate referral to rheumatology, PM&R, pain clinic, orthopedics. Once again, these are not serial processes, but parallel. That means the patient might need to undergo several of these simultaneously. When in doubt, submit an eConsult. We can provide guidance if an immediate in-person referral is needed. If you have questions, you could email me at rajat_bhatt@myprimerheumatology.com. Good resources include for diagnostic criteria, boomtutor.com. And patient education and support groups. I have listed several on my practice website, myprimerheumatology.com. Thank you. We'll open up for questions.
Thank you, Dr. Bhatt, for that excellent educational presentation. We will now be transitioning to our questions and answers session. If there's anything you would like clarification on or you would like Dr. Bhatt to expand upon, please type these into your question box on your screen at this time. We do have 3 questions. Dr. Bhatt, the first question is, what is the most important thing for primary care providers to look for when treating a patient with arthritis?
The most important thing is primarily to not miss one of the red flags. It is important to be compassionate. At the same time, do not miss any of the red flags, as I mentioned, weight loss, which could be a harbinger of malignancy, an inflammatory process like psoriatic arthritis or a rheumatoid process going on. If there's an eye problem, if the patient mentions any floaters, do not miss that, as that could be a symptom of uveitis. And when in doubt, always submit an eConsult, and we are always glad to answer questions. Since this is a very broad topic, so when in doubt, always submit an eConsult, and we can guide you.
Perfect. The next question, what would you say is the most common patient misconception or misunderstanding about arthritis, and how can our primary care providers assist in dispelling this misconception?
Mm-hmm. Most patients with arthritis have kind of evolved to live with it. So they somehow modify their activity, and they tend to know. Some patients complain, but some patients just have adapted their lifestyle to live with arthritis. So they might have an inflammatory process and not even know that there are treatments for it. And so they should always, and quite often they have a bunch of other medical problems as well. So somehow arthritis lands up at number 10 or 20 on the bucket list. So it is important for primary care to bring it up with patients. Somehow patients can, it's important to develop a good patient-doctor relationship so they can discuss their arthritis problems and get treated expeditiously.
Excellent. The last question is very adjacent to the first question regarding common indicators for primary care providers to know when to refer out to the rheumatologist. But what are the main referrals, maybe the top 2 or 3 referrals that you receive in your office from primary care providers?
It depends on the locations, depends on where you're practicing. When I was in Washington State, since the local trend was primary care doctors took care of fibromyalgia, and most extra-articular problems. The patients I was getting was primarily inflammatory arthritis. But in Houston, we have a broader base and different ethnicities. And each ethnicity has its own type of arthritis, which is more prevalent. So here we see osteoarthritis, rheumatoid, and psoriatic arthritis primarily. And psoriatic arthritis goes hand in hand with obesity, and somehow we have more obesity in Texas and Houston. So somehow we see gout and psoriatic arthritis more commonly than I would have seen in Washington State, for example.
Excellent. We greatly appreciate Dr. Bhatt for his excellent presentation on arthritis. We would like to give a warm thank you to our providers and viewers. Special thanks to Sienna Miesfeld for IT and production of this webinar. This webinar, as well as our previous webinars, can be accessed through our website, www.AristaMD.com. If you have any suggestions for topics you would like to see in our future webinars, please reach out. My email is ecladera@arista.com. Lastly, thank you for the leadership at AristaMD, who understand that educational support to our clients and providers ultimately benefits the patients we all serve. This concludes today's webinar, eConsult Strategies for Managing Patients with Arthritis. Thank you.